Hi everyone, this is Reese Garcia, the Research Advocacy Manager with FightCRC. Today we have Liliana and Celia presenting to us on lower anterior resection syndrome. I will let them give their introductions, and just as a heads up, you can use your chat bar at any time to ask questions throughout the Learning Lab, and then we'll also take questions afterwards as well as time permits. So with that being said, thank you both, Liliana and Celia, for joining us today and for presenting on the work you do. We're really looking forward to this. So I will switch over my screen to you now, and we'll get going.
While Celia is getting her slides up, I just wanted to introduce myself. I'm Liliana Bordeianou. I'm a surgeon at Mass General Hospital and Associate Professor of Surgery at Harvard Medical School. And Celia and I are collaborators across the pond. She's all the way in New Zealand, and she and I are part of an even bigger team of surgeons and clinicians who are interested in studying low anterior resection syndrome, and Celia will explain why in a moment. But we're really grateful to have the opportunity to be here and talk with all of you, and appreciate very much your help as an organization when it came to recruiting patients for our study as well.
Great. Thanks, Liliana. That's a really nice introduction. So I'm Celia, and I also want to say quickly thank you to Reese for organising this, and also thank you to everybody that's either joining us now in real time or going to join and listen to this later. We obviously think this is a really important topic, and it's great to be getting a bit of traction on it. So I thought I'd start by quickly also introducing myself and then spend a bit of time with a more general overview of LARS before moving on to talk about the background or motivation for the current project, which is the International Consensus on Low Anterior Resection Syndrome. And then we can talk a bit more specifically about that project itself. So feel free to type or ask any questions. I don't know if I'm quite clever enough to coordinate typing back, but Liliana may be able to while I'm talking, or I can just raise the question in the forum verbally if people are happy with that too. Now, I just have to work out how to go to the next slide. There you go. So that is who you're talking to from our end. I'm currently a research fellow working at the University of Auckland. So I'm working in full-time research while I work towards completing a doctorate in surgery. And my initial topic was entitled Low Anterior Resection Syndrome, a Pathophysiological Definition. So I really wanted to look at the mechanisms that were underlying low anterior resection syndrome. And then when I started some of my preliminary work, I realized that I needed to take a few steps back because we actually don't have a broadly accepted clinical definition that we can even begin this work with in a really robust way. So I'm a medically trained doctor. I've worked in New Zealand and I'm halfway through my training in general surgery, but I interrupted my residency 2 years ago. So I've been working full-time in research for 2 years and will return to clinical practice this December, with the eventual aim of working as an academic general surgeon with a colorectal interest in New Zealand. I thought it may also be possible just to hear from other people what their background is and what their reasons for joining or what they're particularly interested in today. I don't know if that's putting people on the spot too much, but if that was all right, Karen, would you like to introduce yourself?
Karen, can you hear us? I'm wondering if maybe her audio isn't connected.
Shall we ask Stacey if you'd be happy to introduce yourself?
If you all can hear me, there's a bar that says audio. Oh, there's Stacey.
I got it. Okay. All right. I'm multitasking because my disabled son just came home. But I'm Stacy Hurt. I'm a patient advocate. I am battling stage 4 rectal cancer, 3.5 years. I had an 11-centimeter rectal tumor, and then mets to the liver, lungs, and 19 lymph nodes, 27 places in total. And I just had a scan Thursday, and I am officially NED 2 years.
Fantastic.
That's amazing. That's terrific.
So, thank you. I've undergone 55 chemotherapies of FOLFOX. I had SBRT to the lungs, and I'm doing really well. I'm a huge proponent of integrative oncology. My background, I have a master's in health administration and business administration. I worked in physician practice management alongside physicians in their practices, as well as then I was head of training and development for a pharmaceutical company. So that's sort of my background. Like I said, is from the business side, but very entrenched in healthcare before I became a patient myself. And my son suffers with a very rare chromosome disorder. So I learned a lot about genetics as well that has helped me in my battle. And that's why I'm really honored to be part of the RATS program for FightCRC.
Fantastic. Thank you, Stacey. That sounds like a really difficult journey, and you've done so well.
Thank you. I'm very lucky, but I'm very, very lucky, very grateful, and so I feel like I'm here to pay it forward and, you know, to advocate for others, because I think that everybody should be able to beat colorectal cancer for sure.
Fantastic.
And you know, I think Karen.
Thank you for the.
Oh, I'm sorry.
I was going to say thank you for the work that you do too, as researchers, you know, to blaze a trail and end this horrible disease. I just want to thank you for all the work that you do. Thank you.
Yes, thank you.
Thank you.
And I think Karen's audio might be working. Karen, try to say something. Maybe not. All right, we'll get that figured out.
So I also see another Reese listed, as well as Reese Garcia. Is that an additional person, or is that a sort of computer double up?
That's a double up.
Okay. Perfect. So Karen, if you want to at any stage jump in, it's really nice for me to know who I'm talking to, because I have kind of pitched this at quite a lay audience. So if I'm labouring the points too much, feel free just to tell me to speed up, because particularly after hearing Stacey's journey, you have vast experience, much more experience than I have, although I think Liliana probably can add some extra layer of detail. So also feel free to jump in when you'd like to, Liliana.
Of course.
So if we move on to a bit more of a general overview of Lars, I thought we'd start at the beginning, which now seems slightly redundant, but I will. So if we talk about the rectum itself, that's the last part of the bowel before the anus, and its main function is as a storage organ. So it's what allows us to wait and evacuate our bowels when it's socially appropriate to do so. And it's quite a coordinated, complex mechanism of being able to evacuate our bowels. So not only do we need to expel what we've stored, we need to open up the sphincters to let that out. And there's quite a complicated mechanism of motility of the colon, as well as sensing of what's coming down and allowing that process to proceed. So when we do an anterior resection, we remove a diseased part of the rectum and then restore bowel continuity by forming a surgical join or anastomosis between the remaining healthy ends of bowel. In that picture in the top right corner of the screen, there's a shaded or a darker shaded area between two dashed lines, and that's supposed to represent the portion of bowel that comes out with an anterior resection. So in that picture, there's colon in the adjacent left side of the colon in the adjacent rectum that's being removed. I usually think of an anterior resection as something that treats rectal cancer, because that's sort of my area of interest, but it can also be performed on other patients with pathologies like diverticulitis or trauma. And as Stacey's already mentioned, there's obviously a lot of other treatments that are involved in rectal cancer. So we also need to consider things like radiation therapy and chemotherapy. And we need to consider that some of these patients that are having a low anterior resection are also going to need something like a temporary ileostomy so that the waste can be diverted away from that surgical joint while it's healing. And then if we break down the term anterior resection into high anterior resection, low anterior resection, and the sort of third group that's either called ultra low or very low anterior resection, depending on where you come from. These are terms that are used based on how much of the rectum or what part of the rectum is removed. So if you have a tumour in the upper part of the rectum, you just need to remove that uppermost part and the adjacent colon, and that would be called a high anterior resection. Whereas if you're removing the middle part and some of the lower part of the rectum, as well as that uppermost part, that would be a low anterior resection. There's a bit of difference of opinion about what can be called an ultra low anterior resection, depending where you come from, but that generally talks about removing most of the rectum, if not all of the rectum, and then forming an anastomosis between the colon and the anus. So having a coloanal rather than a colorectal anastomosis. And with the improvements in surgical technique, partly owing to some of the new stapling devices over the last 10 years, and the increased use of adjuvant therapies, particularly radiotherapy for rectal cancer, there's been great improvements in oncological outcomes. So this has allowed a broader focus, and people have started to recognise that quality of life and functional outcomes after rectal cancer are very important, and also that survivors of rectal cancer are having significant and persisting problems with bowel function after their treatment. So the overarching term that's used to describe this dysfunction is anterior resection syndrome, or more commonly low anterior resection syndrome, or LARS for short. And I've included Bryant's definition from 2012, which says that LARS is disordered bowel function after rectal resection that leads to a detriment in quality of life. Now that's a very good definition because it also incorporates the impact on quality of life, but it's incredibly broad and non-specific. So that means that this term can be used to encompass a huge range of symptoms, right along the spectrum from fecal incontinence and fecal urgency all the way to difficulty emptying the bowel or evacuatory dysfunction. And on the slide I've put prevalence can be from 38 to 80%, so obviously a huge variation, but that comes with a few qualifiers. It's really difficult to report a general prevalence as there's such different reports in the literature. So the two main reasons for all of this variation are, firstly, that there's no standardization in the way LARS is measured or reported, and that's what we're trying to work on. And then the second reason is because the studies that are reporting prevalence include very different groups of patients who are also undergoing different treatment regimes. So one study may have greater numbers of patients having high anterior resections and not having radiotherapy, while another might report more patients having low anterior resections and undergoing radiotherapy. So the two factors there, the height of the anastomosis and the use of radiotherapy, are the two major risk factors for having low anterior resection syndrome. Although I've said there's a lot of variation in reporting of prevalence, there's really consistent results that these two factors are associated with the development of LARS. And if we think about it from a pathological perspective, the mechanisms make sense. So if you're taking more of the rectum out, you're losing more of that storage capacity, particularly if you're taking all of the rectum out and you're joining the colon to the anus. You've lost that storage organ and you're expecting the colon to adapt and fulfill a storage role. Likewise, if you're having radiotherapy, you're then getting inflammation and fibrosis in the tissues that are now expected to distend and be able to store the waste material, and they're stiffer and not so able to distend, so again aren't acting as a storage organ. The other thing with radiotherapy is the damage to the nerves, And so this is likely to interrupt that complicated mechanism we were talking about, where we can actually evacuate the waste or even hold on to the waste until it's socially acceptable to go to the bathroom. So those are the two big things we know are associated with low anterior resection syndrome, but there are likely to be many other things that are also associated. So some of the things that have been suggested are the use of an ileostomy, increasing patient age, and female gender, although there's some inconsistency in results there. And that's often also due to the variation in patient groups and also in the way we measure LARS. So we think that one of the major ways that we can increase our understanding of this syndrome is by standardizing the way that we report and measure LARS. So even if we're using different studies with different patient populations, at least we're measuring the same thing, and then the conclusions that we draw can be more generalizable to the wider population. There are two instruments that have been specifically designed to measure LARS. So the Memorial Sloan Kettering Cancer Center bowel function instrument was first published by Temple and her colleagues in 2005. It's been used in the US and in Italy, but it hasn't been widely taken up. And then the LARS score was published in 2012 by Emerson and her colleagues. And that was developed initially by a Danish group, but has been subsequently validated in Swedish, Spanish, German, British, and Chinese populations. And if we just have a look at that system, this is the LARS score. So its main strength is how brief it is, and thought to be really easily applicable in a clinic setting, quite quick to fill in. And its other main strength is that it correlates with quality of life. So when the developers were asking their cohort of patients about the symptoms, they also asked, how much does your bowel function impact on your quality of life? And then they used the responses to that question to statistically model the weightings for each of the scores. So if we're looking on the right side of the slide, you can see the numbers associated with each of those different responses for each question. So when you answer each question, you just tally up the scores for each of the 5 questions, and then down in the bottom left, you can see how to interpret that. So if you have answers that tally up to less than 20 or 20, then you're considered to not have low anterior resection syndrome. If the answers tally to 21 to 29, you're considered to have minor anterior resection syndrome. So that impacts somewhat on your life. And 30 to 42 correlates with major LARS. So this is now when we're talking about people that have severe impact on their day-to-day activities or their quality of life. This scoring system has been taken up quite a lot. It's becoming quite prevalent in published literature, but it has been criticised for a few main points. One is that it ignores any of that evacuatory dysfunction or difficulty emptying. So it only asks about flatus and liquid stool incontinence, frequency of bowel movements, clustering, which is opening your bowels again within 1 hour, and urgency, but none of those difficulty emptying symptoms. It also has been criticised for a possibility of being insensitive to change over time. So if it's used repeatedly in the same population of patients, it might not show significant results, even if there has been improvement or deterioration of function. And the other thing that I get back from patients I've been working with in a lot of our studies is that it's very difficult to answer and put your symptomatology just into one of those little boxes. So does anybody have any questions or any comments about what we've talked about at that point?
Hi, this is Reese. I guess one of my questions is, have you found that malabsorption is a major side effect of LARS, or is it something that if it were included on a score sheet like this would have any effect on patients?
Is that malabsorption in the sense that you're having to pass a lot more bowel motions, or malabsorption in a weight loss sense?
More so
What would the sort of symptom?
sense.
I think this is just my own opinion, so I have to qualify it, and I'll be interested in Liliana's as well. But my impression would be weight loss would be such a general symptom that it probably wouldn't be included in something that was specifically looking at bowel function, just because there are so many other influences that could be causing it. So it might be something related to, I suppose, diet, which could then relate to a side effect of nausea with chemotherapy or something like that, rather than more specifically being related to the rectal cancer surgery and the outcomes.
I see.
Does that make sense?
Yeah, that does. Thank you.
I think that it's fair to say, though, that a lot of patients suffering from major LARS are limiting how much they eat as a way of trying to control their symptoms and decrease the number of times they go to the bathroom. And so we do see weight loss secondary to major LARS. And as LARS improves with treatments, the weight loss gets better.
I see.
And so right. So it is maybe not a direct symptom of LARS, but it certainly can coexist.
Okay, thank you.
And so maybe because the LARS score or some other instrument that we might develop to measure LARS is sort of like an identifying tool, so that we can quickly see what patients do need more help with their functional outcomes afterwards. Maybe just having weight loss in it wouldn't be as discriminatory. That's probably a better way to explain what I was trying to say.
Okay, great.
Anything else there, guys? No. So if we move on, I just wanted to talk about this study that we've done at the University of Auckland, because this was our major motivation for really pushing for developing a broadly accepted consensus definition. So I undertook this systematic review with my colleagues Cameron Wells, Gregor Grady and Ian Bissett, and we were specifically looking at the literature over the last 20 years that had reported bowel function outcomes after anterior resection. And as this visual abstract shows, there was huge variation. So over 30 symptoms reported and 18 different instruments used. And the times at which people were asked about bowel function could vary from 4 weeks after surgery all the way to 14 years after surgery. But just to look at that in a little bit more detail, we found over 4,000 papers had actually looked at bowel function outcomes after surgery, but we really wanted to include research that had looked prospectively at outcomes, so not studies that had looked retrospectively at patient outcomes. The reason for that was that we thought retrospective studies were probably likely to include symptoms that had been recorded for some other purpose and were still available to be used, whereas prospective studies were going to be deciding on what outcomes they thought were important and then including those in their research. So we were using the frequency of reporting as kind of a surrogate measure of what authors thought were important outcomes. So after we excluded the studies we didn't think were doing those things, we had 128 papers for the analysis. And as we said, there was a huge variation in symptoms. Over 30 different symptoms were reported. And this graph shows the list of symptoms on the y-axis and the number of studies on the x-axis. The bars are broken up so that the black section represents when a symptom was reported within a structured instrument, and the grey section reports when a symptom was reported in a study outside of the questionnaire or structured instrument. So we think that's important because there's generally been a predominance of reporting around fecal incontinence. So fecal incontinence has been seen to be the sole outcome of interest in a lot of the research papers. And that may be because there's much easier access to instruments that record fecal incontinence. And you can kind of see that with the length of the black bar compared to the grey bar for fecal incontinence. So overall, the most frequently reported outcomes were incontinence, 97% of the studies, stool frequency in 80%, fecal urgency in 67%, and evacuatory dysfunction, so these problems with emptying the bowel, in 47%, and then the inability to discriminate gas from stool in 34%. So they were the highest ranking. There was also a measure of quality of life or impact on life, which is shown by the lifestyle modifications bar in 80% of studies. So as we've suggested, there's a really a focus on fecal incontinence being the important outcome that we should be looking at. But that neglects other important symptoms, particularly things like clustering and urgency, which have been shown to be really important to patient quality of life. And they're also anecdotally what I hear from patients are the most important things. So urgency is a really limiting problem. Keane and their colleagues actually looked at the differences in perspectives between patients and specialists. So they got radiation oncologists and surgeons to rate how much impact they thought that those 5 symptoms in the Lattice score would have on quality of life. And then they got patients to do the same thing. And they found that the specialists in that group, both the surgeons and the radiation oncologists, grossly overestimated the impact of liquid stool incontinence and the frequency of bowel movements, but they markedly underestimated the impact of clustering and urgency on quality of life.
I just want to ask everyone, do we need to clarify what we mean by urgency and clustering, or is that clear? Because it is a little bit of a lingo.
Maybe you could clarify clustering.
And so clustering refers to the situation where one might have 3 or 4 bowel movements very close to each other, each of them incomplete. So they might have one, get up, 15 minutes later, a second one, 15 minutes later, a third one, et cetera, et cetera. And then there will be a short interval where there is a reprieve, and then the cycle continues. So that's what we mean when we say clustering. And so it's not like diarrhea where you're having large liquid bowel movements. It's small, little, incomplete bowel movements, but many of them nevertheless. And then urgency refers to the need to make it to the bathroom rather rapidly. So that sensation of needing to go to the bathroom till the point where you can't hold it anymore is very short. And so an urgent bowel movement may come, even if you have good control, may come too quickly and you might not make it to the bathroom.
Thank you, Liliana. Good point. So if we move on from the symptoms, we also looked at the timing that people were asked about their bowel function, and there was huge variation. So as we said, 4 weeks all the way up to 14 years. In half of the studies, patients were asked at 12 months, and in almost half of the studies, they were asked at more than one time period. But the reason this is really important is because it complicates how we understand the prevalence of LARS. So in that early post-operative period, we'd expect a lot of people to have dysfunction of their bowel habit because they're going to be healing and there's going to be some adaptation to all the changes that have gone on after surgery and or radiotherapy and chemotherapy. And then over time, we'd expect some of this bowel function to settle down as these changes and adaptations occur. So if we're just looking at patients in the early, say, months after surgery, we'd expect a huge proportion of patients to have this kind of dysfunction. Whereas out to maybe 6 months or a year, and then on from a year, we'd expect that the patients that are still having this ongoing dysfunction are going to have persistent dysfunction without treatment. So I would argue that it's the patients out from 1 year that we're really interested in measuring bowel function for and describing LARS in, and that we need to really do a lot more work around what the incidence or prevalence is over time. We also looked at what instruments were used to measure bowel function outcomes in the literature over the last 20 years, and the ignore that first bar for a second, but the Wexner score, the Kerwin classification, and the fecal incontinence severity index are all measures that solely look at fecal incontinence. So again, we're neglecting all of those other important symptoms, particularly the clustering and the urgency that we've talked about, and that really impact on patients' quality of life. The other really interesting finding was that in 36% of studies, which is represented in that top bar, there was no specific instrument used. So this was no structured questionnaire and not a validated instrument. And so this is suggesting that authors are just reporting symptoms that they personally deem to be of importance. When we looked at the scoring systems we've talked about, so the LARS score, that was only used in 5% of studies. But as that was over the last 20 years, if we just concentrate on when it was used since its publication, it was actually used in 23%. The bowel function instrument was only used in 3 of the studies. So as we said, hasn't been widely taken up. Now, similar reviews, sorry?
Sorry, I was just saying that it makes sense because the Memorial Bowel Function Instrument has 18 questions. So the researchers usually tempted to offer questionnaires that have the smaller number of questions. But the concern, as you stressed, is that if you use an instrument that only has 5 questions, how do you catch a change or an improvement with treatment? So it's hard to discern subtle improvements or subtle deterioration over time, which is why there is more work to do as well.
Thank you. And sorry, I should have pointed out actually that the 18 questions in the bowel function instrument do cover those important areas that some people think the LARS score is missing. So they have more questions about evacuatory dysfunction, the inability to discriminate gas from stool, and they have a lot more questions about the impact of diet or the need to restrict certain foods and fluids to control your bowel function. So it is a much more comprehensive tool. So if we just move on, that's kind of been our motivation for then developing this study that we've just launched. So the whole aim, or the overarching aim of this study really, is to work towards a broadly accepted international consensus definition of low anterior resection syndrome. And I've tried to make the point that I think this is really an important step to enable us to have a robust measurement of LARS, not only so that we can more accurately look at the prevalence or how common the problem is, but so that we're able to identify what risk or associated factors there are and what the underlying causes of a LARS. And that might enable us to be able to tailor treatments to limit the impact of bowel dysfunction. But probably more realistically, it will enable us to better inform patients about what to expect after their treatment. And I think it will also help us to more accurately assess treatment strategies for low anterior resection syndrome. So this international consensus on LARS is a collaborative study with representatives from all the tripartite organisations, so with the logos represented along the bottom of the screen. We've got the American Society of Colon and Rectal Surgeons, the Association of Coloproctologists of Great Britain and Ireland, the Colorectal Surgical Society of Australia and New Zealand, the European Society of Coloproctology, the Royal Australasian College of Surgeons, and the Royal Society of Medicine. So it's been quite a broad group, and our scientific committee who's overseeing the project are made up from representatives from all of those organisations. And they're also representatives from each of the 5 regions in which we're conducting patient recruitment or coordinating patient recruitment from. So Professor Bissett and I in Australasia, Australia and New Zealand, and Liliana with Anders Malmgren and Guy Arangio in the US. So what we've done is we've recruited participants to sit on one of 3 expert panels. There's a patient panel, a surgeon panel, and a health professional panel. anyone on the patient panel will have undergone an anterior section at least 6 months ago, and they don't necessarily have to have LARS. What we'd really like would be for people to have a spectrum of post-operative experience as well as a spectrum treatment, so some people that have had radiation, some people that haven't, and a spectrum of more general demographics like age and gender. And anyone that's on the surgeon or the healthcare professional panel will work in the field of post-rectal cancer treatment bowel function. So the health professionals might include people that are working as nurses, physiotherapists or biofeedback specialists, gastroenterologists or radiation oncologists. And we've been really lucky to have the support of a lot of charitable organisations that are working in this area. So of course, Fight Colorectal Cancer in the US, Beat Bowel Cancer in New Zealand, Australia, and the UK, and quite a few others. And we've had a lot of support on social media. So we've done all of our advertising for the US and the UK recruitment via social media so that patients are self-selecting. And that's done via these online registration forms and the online information sheets, as well as ads on Facebook, Twitter, and on the ASCRS website. So then the study itself can be broken into 2 parts. The first part is an online Delphi survey with 3 rounds of questions. So the Delphi survey, or the Delphi method, is a method that's used to try and reach consensus. It's a way of doing a survey where there's an iterative process, so that after each round of questions, the next round of questions will be informed by the responses from the previous round. So we have a list of questions that ask about how important each symptom is to be included in the definition of LARS. So how important each symptom is to be measured effectively when we're talking about bowel function. We've got things like fecal incontinence, clustering urgency that we've talked about, but there's a whole list of 37 symptoms. And then these symptoms can either be voted in or voted out when we look at the overall responses. So the next round of the survey will only focus on symptoms that have been voted in or there's been contention over. And after each round, all the participants get a summary which shows their own responses to the questions, and then the average response for all the other panelists in their group. So the idea is that when people see their responses with the averages from the group, there might be sort of an ability to rethink some ideas, and then everybody will be able to reach a consensus. After that online survey, there'll also be consensus meetings. So first, there'll be patient consensus meetings, which are held for each of the regions. In places like Denmark, which are quite geographically close, there'll be a face-to-face meeting, while in Australia and New Zealand and in the US, there'll be online meetings. And participants on these patient panels will all be invited, but they don't necessarily have to attend their regional meetings. The meeting is a chance to clarify any of the unresolved items, so items that weren't voted in or voted out but remain contentious throughout the 3 rounds. It'll also be an opportunity to clarify terminology and raise any concerns that came up during the survey. And then after all of the patient consensus meetings, there'll be a final consensus meeting with representatives from all the panels, so the surgeons, healthcare professionals and patients. And that's going to be held in conjunction with the European Society of Coloproctology meeting at the end of September. So the aim of this final meeting is to bring together the voices from all of the respective panels and create a consensus statement that's going to include a definition of LARS. So we think it's...
Yeah. For the American people like us, the meeting is in France. So it's an extra motivator for some of us to have an excuse to go and travel to Europe.
Good point, Liliana. Professor Bissett and I are very much looking forward for our trip to France.
Yeah.
But it's a very ambitious project. I think we're making really good progress though. We went live on the 11th of March, so there's been 270 people that have registered so far, and we've already had 120 completed surveys for that first round. And we've got a great team of people working with it and really engage participants. So I think it's going to be a really good piece of work, and I'm hoping it's going to advance how we think about LARS and how we go on looking at measuring LARS and doing research on LARS to improve our understanding of it. Is there any questions or comments?
That was great. Thank you both so much for the presentation and for this overview of this this meeting, this collaboration in France. That will be very exciting, I'm sure. You know, one thing we've heard as a patient advocacy organization from patients in terms of LARS is that oftentimes providers aren't fully aware of LARS or the symptoms or how to treat it. So when you all were doing your research, did you ever come across any barriers or any findings that demonstrated that providers might lack the education geared towards LARS? And if so, what were some of the ways of overcoming that?
I think this is an outstanding question, Reese. And I think half of it is that for the providers to actually use the same language when they're describing LARS. A lot of providers know how to treat fecal incontinence. So if LARS were just fecal incontinence, the treatment is, you know, the surgeons and the gastroenterologists are pretty well trained to deal with it. But because LARS is so much more complicated and there are so many extra symptoms weaved in, the understanding of how these symptoms combine together and what triggers them is actually very, very primitive. And so it's not that the doctors don't get the training. I don't think that doctors even understand what the disease is all about and how some things make it better or make it worse. There was so much focus over the years on cure at all costs. And I think that the part about quality of life after treatment sort of took a little bit of a second place. And it's only now that there is more interest in survivorship research, essentially, and in making sure that the patients are actually living meaningful lives in addition to being cured.
That's a great point. So some sort of collaboration with survivorship, whether it's treatment care plans, but making sure that it's integrated as a patient leaves treatment, because this is something, if I'm correct, this is something that can last up to 10 years. Is that right? Or is it something that can be lifelong?
Absolutely. The study that looked at whether or not patients have LARS at 14 years documented severe LARS in over 50% of patients that responded to the survey. So yes, LARS can last as long as a decade, but what we don't know is, did it last for longer than a decade because people didn't get treated? Because it is possible that people simply did not get the treatment that they needed because there is, you know, if there is not even a term that everybody can agree on, forget about doing research on what might make it better or make it worse. So once we have a tool that everybody agrees to use, one can start then saying this intervention alters the disease.
I see. And that's a great start. What, I guess, as a provider, have you found for patients is a really good treatment route as of what we know right now and what we've agreed on for the language and the signs and the symptoms? What would you recommend as being?
So at this point, we still have to break it down by the actual individual symptoms that the patient may have. So if it is the fecal incontinence that's the most prevalent symptom, then we'll focus on that. And there is actually a lot of interventions, from medications to interventions like sacral nerve stimulation and artificial bowel sphincters. So fecal incontinence is one of the easier ones to treat. Where it gets tricky is when you have, you know, incontinence mixed with clustering or incontinence mixed with poor emptying, because if you know, try and constipate somebody, then their poor emptying gets worse. And so it's the yin and the yang of managing it. And, you know, at least in the United States, one of the discoveries that we're making as we're, you know, recruiting the participants for the study is that the majority of this treatment is actually provided by the surgeons. And so if the patient has a good relationship and is seeing the surgeon frequently after surgery, then they may get some help. But if they got their care very far away and then they never back in communication with their surgical group, they sometimes may have no access to any provider whatsoever. And so not even the most rudimentary treatments would be offered, you know. So that sort of will raise questions as we go along about who else should be involved in the treatment of LARS. Should we, you know, train the primary care physicians, for example, to recognize the disease?
Right.
Because I don't think that they're aware of it.
So then with the state that LARS is currently in, if a patient does go to their oncologist and their oncologist doesn't give them great next steps or isn't, you know, aware, what do you recommend as a physician next steps are for a patient who might not be getting anywhere with their doctors?
So the best way to get care in the United States right now would be from a physician that treats pelvic floor disorders. So some places have centers for pelvic floor disorders, and these are usually providers, both gastroenterologists and surgeons and physical therapists that have interest in every kind of dysmotility, including iatrogenic dysmotility like LARS, and that would be the team of docs that is most likely to provide help to this patient population.
Wonderful.
Yeah.
Well, that's great. That's great advice. Thank you. Does anyone else have any questions before we let Liliana and Celia on with their day?
Hey, it's Stacy again. And again, I just want to thank you for your research, particularly on LARS. So I didn't even know that I have this. I was limiting my symptoms just to the fecal incontinence. So this has been very, very helpful for me, because when I was looking at your scoring instrument, I realized all the other symptoms that I suffer from, thus comprising the syndrome. So I am completely enlightened, and I just want to thank you for your elegant presentation today, because I will now educate others as to this syndrome. Like I said, I had no idea that this is what I had. And I am, just so you know, my resection, I did not have to have an ostomy. I was very fortunate in how like I said, it was originally an 11-centimeter rectal tumor, and it shrunk up, so I didn't need a bag. And he was able to resect successfully. So here I am 3 years out from my surgery, and if I were scoring, you know, 3 years, still suffering with these symptoms. So I'm hoping that that's helpful for your research also.
Absolutely, and I'm sorry you're still having symptoms. We usually hope that patients improve after 1 year, but it also sounds like because you didn't realize you had the symptoms, you didn't necessarily seek care for them. Exactly.
Right. I was mostly just thinking they were par for the course. I was ignoring them, just thinking it was part of the healing process, or this is just what I had to live with. It's great. They've greatly impacted my quality of life, and now I'm educated. So thank you.
I think sometimes just having a word to describe what one experiences is helpful, because then, you know, that can help tailor the treatment to that particular issue. Mm-hmm. So that's why we need the help of all the patients that are signing up for the study too, because sometimes we're aware of what we know, but we don't know what we don't know. And so we like to go back to the drawing board and actually figure out what else the patients are experiencing. So, looking for learning.
Yes, no, I'm sorry. I was just, I agree. Like you said, how to quantify them is so helpful. And Teresa's point, taking those symptoms back to our providers so that they can help us seek treatment. I love my surgeon dearly, but I can tell you that he had not intervened at all about you know, these particular symptoms to give me any sort of relief. So I think that patients like me can help bridge that gap then with the providers to help with this.
That I agree.
Yeah.
Well, thank you for raising that too, Stacey, because I think that's one of the really nice outcomes that we're starting to find with this study, actually. I mean, our focus was about the definition and moving forward with that, but there's actually been such a good groundswell in social media and in my interaction with patients, and I'm sure the other regional centres interaction as well, that we're really hopefully advertising this more. And so people are educating themselves, even if they're not getting it from providers. Patients are able to educate themselves and then take the steps like Liliana suggested to go and access help.
Yeah, I'm happy. As Reese knows, I'm very prevalent on social media. I'm more than happy to help as a patient survivor suffering with LARS. I'm happy to help further the effort any way I can.
Thank you.
Fantastic. Thank you.
Thank you.
Thank you both. Are there any other questions? I know we had I'm glad this was a great discussion today. And I think LARS is a very pertinent topic right now, especially to patients that have gone through treatment and aren't really sure what these symptoms mean. And kind of like you said, Stacey, knowing you have a major symptom, but what are all the smaller ones that kind of conglomerate to create, to make it LARS. So this has been very helpful. And if any of you think of any questions after we jump on the call, feel free to email me and I can push them forward to both Celia and Liliana. I want to thank you both so much for jumping on a call with us today. And I will send over the recording to you once it's finished uploading for your records as well.
Perfect. Thank you so much.
Thank you all.
Yeah, thank you.
Thank you.
Have a great day.
You
Thank
too.
Bye.
Bye.
Bye.